Pradnya, I'm here only.
Sir, should we start?
Yes, please. It's 4:30.
Yes. So, good afternoon, everyone. I welcome you to the Foxy ICOG JOGI Research Methodology and Journal Club. And we all know that every second Tuesday of the month, we hold this important program of Research Methodology and Journal Club. I request others to please mute themselves. So for this, I would request Nilima to share the screen, which will have the CVs of all our dignitaries. We have the blessings of our Foxy President, Dr. Sunita Tandulwadkar ma'am, for this program. And we have Chairperson ICOG, Dr. Parag Vinewale sir. He's present there. And the conveners for today's program, Dr. Sujata Darvi ma'am and Dr. Radhika AG. So can we have their CVs? Yeah, so we all know Dr. A.G. Radhika. She is a national corresponding editor of JOGI and she has received several awards and is an expert reviewer for Cochrane collaboration. Welcome, ma'am. Dr. Sujata Darvi, ma'am, she is the editor-in-chief of JOGI and she is a clinical associate at Vadia Hospital and several hospitals and secretary of MOGS. We have Dr. Sunita Tandulwadkar, ma'am. She's blessed our program. We know she's a dynamic president of Foxy and madam is not able to be present here, but she's conveyed up, her best wishes for the program. We have between us Dr. Parag Vinewale sir. He's a chairperson of ICOG, president of Menopause Society, president.
Pradnya, thank you. Thank you. Don't waste time in reading that. Thank you.
Can
Good
I
evening.
request you to speak a few words, sir?
Sure. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to welcome everyone for this episode of Foxy ICOG JOGI Research Methodology and Journal Club. At the outset, let me appreciate efforts put in by the conveners, Dr. Sujata Darvi, the editor-in-chief of JOGI, and Dr. A.G. Radhika, who's our governing council member, ably assisted by Dr. Pradnya Changede, Dr. Sunil Tamvekar, and Dr. Pradnya Supe. Thank you for being so consistent and taking this program ahead. I welcome all the faculty today. First and foremost, a warm welcome to Dr. Mala Arora, past chairperson of ICOG. Welcome, Mala. Pleasure to have you on this program. And I also welcome Dr. Kavita Bhatti, Dr. Jayashree Srinivasan, I believe she's yet to join, and Dr. Sanjeev Datta. Thank you for agreeing to be the chairpersons for today. There are two interesting papers that we are going to look at, will be presented by Dr. Jyotsna Dwivedi and Dr. Vishnu Priya. And of course, this will be followed by a software demonstration by Dr. Sunil Tamvekar. So I'm looking forward to some interesting learning experience and my best wishes for the program and happy learning. Thank you very much.
Thank you so much, sir, for those inspirational words. May I request Dr. Sujata Darvi, ma'am, to please share a few words with us?
Yes. I wouldn't take much of your time, but I would reiterate whatever Dr. Parag Vinewala has said, and then let us start with the program. It's not a problem. Then we'll give some, concluding remarks at the end.
Okay. Radhika, ma'am, would you like to address the audience?
So, welcome all, and ditto from my side, same as what it's been already spoken. So, for us, it's
Yes.
become almost like a routine, and it's a pleasure to see the new experts and the new faculty who is showing the entire support by their presence. Thank you so very much for being here. And Dr. Parag, Dr. Sarita, special mentions and their acknowledgements for being present here. Thank you so very much.
Dr. Sunil, thank you so much, ma'am. Dr. Sunil, can you introduce the other faculties?
Yes. Good evening, ladies and gentlemen. So let us move ahead with the program. We also seek blessings from other senior office bearers from Foxy and ICOG. Ms. Nilima, kindly share the PPT. So Dr. Suvarna Khadilkar, madam, who is the Secretary General Foxy, past President MOGS. Madam couldn't be there right now. Thank you for joining. Dr. Ashok Kumar, sir, he is from Delhi, Senior Obstetrician and Gynecology. And Dr. Sarita Balaram, madam. Now she is currently Secretary ICOG. She is present here. We seek your blessings, madam.
Thank you, Dr. Sunil, and it's a pleasure to collaborate with the JOGI for this program every month. And I'd really like to congratulate Dr. Sujata Dalvi, Dr. Radhika, and the team, Dr. Pradna Chengade, Dr. Pradnya Supe, and Dr. Sunil Tamvekar. It's a pleasure to have Dr. Mala Arora, and it brings back many memories of our programs that we've done together in ICOG. And before the program starts, I'd just like to say that for all the delegates who are here, you can apply online for FICOG this year. It will be given in Delhi, and the applications will be closing 30th of September. So please do go to the website icogonline.org and do apply. With that, I wish you all a lovely evening. I'm sure it's going to be great learning. Thank you.
Thank you very much, madam. So I invite expert chairpersons for the program today. We have seniors, 4 of them with us. It's my proud privilege to introduce Dr. Mala Arora, madam. She's senior obstetrician and gynecologist. She has been FOXY vice president in 2011 as well as ICOG chairperson 2017. She's a senior leader and we need blessings and guidance from you. We welcome you, madam. Dr. Kavita Bhatti, she's senior obstetrician and gynecologist. She's professor and head at CMC and hospital at Ludhiana, Punjab. She has been heading various positions and organizations, including Ludhiana OBGY Society, where she was vice president. She is receiver of many awards. We welcome you, ma'am. Dr. Jayashree Srinivasan, Madam is senior obstetrician and gynecologist from Chennai. She is from VHS Hospital, Adyar, and she is a retired HOD and professor, Department of OBG, Savita Medical College and Hospital. She is senior FOXY leader, and thank you for joining me. Dr. Sanjeev Datta, he is among the young clan and leaders in FOXY. He's from Kolkata. He's associate professor at College of Medicine's Sagore Datta Hospital, Kolkata. He's also being at various positions at FOXY and committee. We welcome you, sir. So once again, we welcome delegates and all the faculty. I request one of the chairperson to kindly introduce our first speaker. She is Dr. Jyotsna.
It is my pleasure to introduce Dr. Jyotsna Dwivedi, who is an assistant professor in the Department of Obs and Gynae, St. G.S. Medical College and KEM Hospital. She has 8+ years of clinical and teaching experience, and her special interests are high-risk pregnancy, urogynecology, and research and academics. And we need people like you, Dr. Dwivedi. I think it is such a pleasure to introduce you and to help you continue on this journey of academic excellence.
Thank you. Thank you so much, ma'am.
Over to you. Present.
Yeah, Dr. Jyotsna, you can share your screen and you can start the presentation.
Yeah. Thank you, Dr. Sunu. Just a second. I'm so sorry. It's
No
taking.
problem.
Is my screen seen now?
Not yet, but take your time, don't worry. I think sometimes this happens, but in the meantime, I wanted to just add one more sentence. I think this is an excellent initiative, Dr. Sujata, Dr. Parag, Dr. Sarita. I think this is my first time being on it, but I'm really honored and so proud of this initiative. I think this was the need of the hour to get our own researchers, our own journals, our own data. And like Dr. Dwivedi, there are many others who we want to encourage and want you to participate in more studies, even though it is less fruitful than clinical work, but it goes a long way. There we are. We can see your screen. Perfect.
Good evening, everyone. Um, I'm Dr. Jyotsna, and thank you for such a good introduction, ma'am. I would like to go ahead with my presentation. So today, I'm going to present our study, which we conducted in the Department of Obstetrics and Gynecology at CGS Medical College. The title of the study was Maternal and Fetal Outcome of Leptospirosis in Pregnancy. Actually, the whole point of taking leptospirosis as the thing, as a point of study was that there was very little data available related to whatever work we are doing and specific to pregnancy and fetal outcome. There was not much of the data available. So that is why we and since it was at this, when we decided to do the study, that time we wanted to initially collect the data that is available, the work that we are doing, and how many patients that we have managed from that. And carrying forward, we would like to consider taking this ahead, this study ahead also in coming days. So, maternal and fetal outcome of leptospirosis in pregnancy. I would also like to thank my other co-authors, that is Dr. Dhruvi and Dr. Gaurav Desai, Dr. Kimya ma'am, and Dr. Niranjan Maidev sir, who have been a constant support and help for me. So, I'm not able to move this slide ahead. Yeah, so this was basically, so background of the study, leptospirosis, as we all know, that it's a zoonosis, but it is a neglected one with a varied severity, and many a times the need to consider this was because there are this particular disease is re-emerging due to the climate change, urban poverty, the uh, the population being involved. It is often underdiagnosed and often underreported. For us as obstetrician and gynecologists, it is important because it mimics many a times as health, that is hemolysis, elevated liver enzymes, and low platelet count condition, and also might present as acute fatty liver of pregnancy, liver in pregnancy. So the objective of the study was basically to evaluate the maternal and fetal outcomes and to estimate the prevalence of leptospirosis in a tertiary care center in an endemic area such as ours. Now, the study design and setting, as I mentioned, that the data was, it was a retrospective study. It was observational descriptive study, which was done at a tertiary care teaching hospital in Western India, as this part is the endemic for leptospirosis. The duration of the study was from January 2018 to December 2022. And the study was approved by the Institutional Ethics Committee. Coming to the methodology of the study, it included the data related to the pregnant women with IgM ELISA confirmed leptospirosis. The data was obtained from the Integrated Disease Surveillance Program Committee, which maintains the data of leptospirosis positive patients treated and their outcome. It excluded the patients with significant comorbidities, as we were specifically seeing the effect of leptospirosis in patients of in pregnant patients who did not have any other comorbidity, which might be necessary, which might have resulted into any kind of elevated liver enzyme or any kind of features that the patient presented. The total number of patients that the data which we could gather was around 37 over the duration of 5 years, and then a descriptive analysis was done. Now, as per the data that was collected, the baseline characteristics that we could be seeing was, as per the Kuppuswamy scale, 59.5% of patients belong to the low socioeconomic strata of the society. The most common season in which the patients were admitted with leptospirosis was in consensus with the other studies that have been performed in all over the India. It was mostly from July to September, and around 54% of the patients were presented in first trimester. This basically could be because in the third trimester, the patients are not very much moving around and coming in contact with maybe the dirty places where she has to go or something like that. And that is why it was found in our study that around 54% were involved, the patients who presented with fever were in the first trimester. The clinical features that the patient presented with were mostly fever was the most common symptom. But apart from that, the patients also had abdominal pain, vomiting, headache, and jaundice. The lab findings, which were most significant, were that 54% of the patients had leukocytosis, anemia was seen in 51%, hyperbilirubinemia was seen in 32%. The deranged LFTs were seen in case of 16% of patients, which included hyperbilirubinemia and deranged transaminases. Creatinine was raised in only 8% of the patient, whereas thrombocytopenia was seen in 5% of the patients. The maternal outcomes, as could be made out from the data, was that 19% of the patients had sepsis. ICU admission was required in case of 4 patients. Weil's disease, that is one of the extreme forms of leptospirosis, was seen in case of 2 patients, out of which 1 became a mortality and 1 successfully went home. In the patients who were followed up further, 5% of them had antepartum hemorrhage and 8% had postpartum hemorrhage. The fetal outcomes that could be seen. Out of the total patients, 5 had spontaneous abortion, whereas 2 had to undergo second trimester abortion in view of presence of congenital anomaly in the fetus. 1 had cardiac anomaly and 1 had multiple structural anomalies present. Out of the other patients, 3 had IUGR, 2 had intrauterine fetal demises, and the preterm deliveries were seen in case of 8 patients, and term deliveries were seen in case of 59.4% of the patients, that is around 22 patients. Coming to the neonatal outcome, the mean Apgar score at the birth at 1 minute was 9 by 10. There were 5 in ICU admissions, mostly for the low birth weight and prematurity. Only 1 term neonate was admitted in an ICU with hyperbilirubinemia. This coming to the discussion part, as it is mentioned that leptospirosis mostly presents as it generally mimics with many other features. Fever, though considered as a very common symptom, it might not be present, and patient might directly come at a stage where the patient is presenting with hyperbilirubinemia. So a pregnant patient presenting with hyperbilirubinemia mostly leads us to a wavered diagnosis where the patient can be considered as a HELP along with other features, or a diagnosis of AFLP can also be considered. So this is very much important to know while treating a patient that leptospirosis is also one of the diagnoses if the patient gives a history of having a kind of mild fever also in the past 1 to 2 weeks. Then poor hygiene and monsoon peaks are definitely a higher risk, and hence proper information education should be provided to the patients so that we can early identify their condition and can help them in treating properly. Vertical transmission possible in mild infection, though this is one of the possibilities that has been mentioned, but there are no certified data which say that there is a vertical transmission possible, and hence more research is needed in this aspect. Fetal death as predicted, we just had, as per our study, there was intrauterine fetal demise, but it not at this stage when the patient had fever. One intrauterine fetal demise was seen in case of a Weil's disease patient who herself became a mortality. So they, as per the possibility, it could be due to the inflammation and poor fetal response that is seen as per due to multi-organ involvement of the mother, multi-organ failure, and that is why there was the fetal demise. Coming to the limitations of our study, as it can be seen, it is a retrospective study. So plus it's a single center data over a period of 5 years in which there were only 37 reported cases of leptospirosis with pregnancy. So it also include the duration also included COVID-19 pandemic. So we can see that there might be underreporting of the cases also, and hence we need to have a larger size and maybe multicentric data collection and prospective study would be a better way of finding out the exact maternal and fetal outcomes in patients with leptospirosis. So coming to the conclusion, leptospirosis is underdiagnosed and potentially fatal, as I mentioned earlier. Again, proper education, proper suspicion, early suspicion and testing is crucial in febrile antenatal patients, and including lepto and differential diagnosis is very important in cases where there is in the areas which are endemic to leptospirosis, and also during monsoon season, it can be included in differential diagnosis in areas where even leptospirosis is not endemic, but can be a cause. going through this study, like while collecting the data related to this study, few things that we realized was awareness among the clinicians, or basically maternal physicians, is very much important, as we this disease can mimic our obstetric illnesses also. So, considering that a patient can also have a leptospirosis is very much important. Leptospirosis, lepto-IgM in routine fever panel should be included, and public health measures such as sanitation, education, and prevention should be advised to the patient whenever we have a first contact with the patient, and we are able to impart any kind of information to her related to this disease. So, this was our study, and I would like to conclude. Thank you. I would also like to thank the Department of Medicine and Community Medicine from our institute, who helped us to gather the data and present.
Dr. Mala, ma'am, you are muted. Hello.
Yes,
Yeah.
ma'am.
Okay, Dr. Mala seems to got disconnected.
Yeah.
Meantime, Dr. Kavita, ma'am, you can go ahead with
Yes, yes.
the discussion and
So,
question.
Dr. Jyotsna, I think it is a very good observational descriptive study that you have done on a very uncommon topic. And as you said, it is mostly undiagnosed, because as clinicians, sometimes we do not consider this as a diagnosis when we are looking at patients who come to us with preeclampsia, HELP, and acute fatty liver of pregnancy, because as you said, leptospirosis mimics those conditions. But many a times it skips our mind also. So there are times when you should take a proper history, I feel, especially when, as you said, in the monsoon season, it is more prevalent. And since it is a zoonotic disease, we should always ask how much exposure there has been in the patient to animals or to water, such as flood waters, recreational activities, etc. That is a cause of causing more of this leptospirosis. So history taking and awareness is very important among the clinicians as well, I feel, because one has to consider this as a diagnosis, possible diagnosis when you see patients where there is impairment of the liver function and kidney function, multi-organ failure, because once it goes beyond a certain stage, then the patient may have problems and even lead to maternal severe morbidity and mortality. So I wanted to ask you, did you, 54% of the patients presented in the first trimester, Dr. Jyotsna? And what about the others? Like, did you compare the adverse, did you see what was the adverse maternal outcomes in the second or the third trimester? Was there any difference?
Ma'am, actually, the adverse maternal outcome, the one patient that we lost to Weil's disease was in her third trimester, ma'am. And the other one, who went home, she was a second trimester patient. So, but again, as I would like to say that this is a retrospective data that we could just go through. So considering, I mean, the prognosis of the disease in the third trimester was worse is because I had a mortality. But if in case I was doing a prospective study, I would be in a better position to answer this, that which particular phase would be more affected by the disease if in case the data was collected in a prospective manner. So.
Okay. Did you come across any systematic reviews when you were considering literature search on this topic?
Yes, ma'am. Yes, ma'am. There's this Dr. Selva Raja's systematic review is there, in which he has also concluded that because of the prevalence of this disease and it being endemic in certain areas, they have also had such kind of like even their data for that matter. They were also of the opinion that we require a more comprehensive data and we require more studies related to this thing. But yes, they have said that the the disease has a poor prognosis if misdiagnosed, if undiagnosed, till the later stage, till it ends up involving the multiple organs. If it is misdiagnosed, then definitely the worst prognosis is there during the third trimester as compared to the other two trimesters.
So because I was reading your observational study, I went through one systematic review, which was the first one in leptospirosis in pregnancy.
Yes.
And that was published in 2021. And what they have said that if it affects in the second trimester, it is more prone for giving more adverse outcomes in the mother, especially, rather than in the third trimester. That was their observation from the systematic review, where they included case control studies and other observational studies.
Yes.
So that was one. And they gave three key messages at the end. Ask early. Ask early is you have to ask about the risk factors, treat early, and third is report well. So lot of times we do not diagnose it because we are unaware. And secondly, treatment, obviously, we need to start early. And third, we need to report also so that we get more robust data in the future as well. So I think your conclusions also are well. And are you planning to take it to other centers?
Exactly.
Yeah. So, ma'am, we are still under the process, we are still sorting out the nitty-gritties of it, but we will definitely think about involving other centers and specifically Maharashtra being endemic for leptospirosis. We definitely want to do a good work in this thing so that we are able to come up with de- like there were
Yeah.
I'm
Better
little
data.
diverting from my topic, but still, there was also a confusion related to congenital anomaly. Two of our patients who had presented in our in first trimester had to undergo medical termination of pregnancy in the next trimester, like in the second trimester. But still, just two
That
patients
question
cannot
is
lead
still
to a data. Yeah.
unresolved. No, my plea to you would be that this should be taken up as a prospective study so that we have more robust data. Secondly, I found a paucity of vertical data on vertical transmission, which I'm sure you feel the
Yes, ma'am.
need and the pediatricians
Exactly.
will feel a need to make sure that the neonate doesn't undergo any complications. And thirdly, pregnancy being an altered immune state, it will lead to worse prognosis than the non-pregnant state. But more important than that, I wanted to bring to the forefront that we're not just talking about endemic areas and a particular season, because if you read case reports, then it has been transmitted through conjunctiva, through abrasions. And I read a very interesting case report in a non-pregnant patient who drank Coke from a can, and those cans were stored in a warehouse where a rat had peed on the Coke can,
Yes.
and that led to impregnation of the top of the Coke can with leptospira. And this healthy young woman just drank Coke on a cruise or something. And then by the time the ship landed, she died because she kept having fever and no one could diagnose what it was. And ultimately, her postmortem showed leptospirosis. So I mean, it
I
is a
think that
very,
was in the news, ma'am. I
yes,
read it
right?
somewhere. I think it was
Yes,
in the
yes,
news.
yes. Okay,
And after
Dr.
that, I
Sanjeev.
stopped drinking from cans directly.
I think that public awareness is so
Yeah.
important. Yes, Dr.
So,
Sanjeev, I think you want to make a comment too.
Yeah. First of all, I must thank Dr. Sunita ma'am, Dr. Porak sir, Dr. Subarna ma'am, Dr. Sarita ma'am, and Dr. Sujata ma'am, and Dr. Sunil for this first time appearance in my first ICOG webinar. So it's definitely, I'm really feeling privileged. To Dr. Jyotsna, she has really presented this topic so well, and it was a really very exhaustive collection of data over a period of 5 years. And and obviously, I must say that she has highlighted the major concern areas in leptospirosis in pregnancy. But what I was thinking in a different way, that she actually collected in this study, it was collected only the fever cases. All fever cases it was collected initially, and then the leptospira cases were segregated, and then the problems that has arisen out of these leptospira cases were analyzed in terms of proportions or say ratios and complications like that. So therefore, there was no control in this study, and only cases were taken. So proper statistical analysis could not be made in this study. I think it was a different kind of study, obviously, and making a control is really a tough job in this case, obviously. But this we could differ. We could make it in a two different groups. Like one is leptospira group, another one is febrile, other febrile illness, or
Exactly.
maybe only the viral illnesses, because we cannot include dengue, malaria. These are all different scenarios. So we could compare it between our normal viral fever cases, which are so prevalent, and along with to that of leptospira cases. Then possibly we could make a proper statistical analysis whether leptospira is causing additional risks to the maternal and fetal. Because our primary aim in this study was to calculate the maternal and fetal outcome in leptospira. Then if we want to really think about the risk involved in leptospira cases, then along, I mean, to which we are actually comparing with. So that is one area that I was thinking about. Do we have any opinion about that? From Dr. Jyotsna, do you have any
I,
opinion?
as I told you, sir, this was a retrospective thing, and I totally agree with you that there was no
Mm.
control. And as you mentioned, that the methodology was to collect the fever patients, and out of that, those who turned out to be leptospira positive, we took those data. So that is why, putting it on paper that leptospira has affected in this way or that way, that is the limitation of my study. That this is not conclusive, and I would definitely want to go ahead and do a case control study or a prospective study where I am in depth studying about what exactly happens when a patient is leptospira positive and follow her through. If in case she's a first
Yeah.
trimester patient, I would want to follow her throughout her pregnancy. And whenever, like in whatever trimester she's presented, I will definitely want to know what exactly are the changes that are
Mm.
happening. Here in our study, we just went through the data. We just went through the
The,
papers of the patient.
the
So
trouble
there
is
was no,
that
yeah.
leptospira serology is not commonly done by
Yes,
obstetricians in fever.
Yes.
So first
Yeah.
step is to increase awareness of doing that serology. Unless we do it, we don't know. We can put it down
yes,
as viral most of the time, and
But
then
yeah,
the patient
yeah,
mostly
one
recovers.
point is it was mentioned in the study that IgM stays long in leptospirosis
yes, yes. This is
compared
a
to
very
other
big,
diseases. So that is one point, that whenever a patient is coming with febrile illness, whether that is because of the current leptospira infection or because you are getting positive report because of the past leptospira
Fast.
infection,
exactly,
so
sir.
that is a real problem
That
with the
also,
thing.
yes,
Yeah.
sir. So that was one of the this things, sir, and for which we had to, like, actually, there were in fact our study also mentions that in few patients where there was no diagnosis, but PCR was done because
Yeah.
they were at their wits end to what is to be done, and through the papers I could find out that at the end it was decided to let's go for PCR for leptospira. So if I think whenever we are dealing with a patient, we also need to have a physician's opinion when it comes to
Exactly.
True.
comprehensively managing the patient, where
Right.
we are not able to identify what is the cause. Maybe somebody who is an expert into that field may be able to help us in a better way. So,
Obviously, but the point is,
Jayashree,
whenever we are getting leptospira cases, it has to be dealt in a more careful way, and because
yes,
a lot more complications can happen out of leptospira. It can go anywhere. It can involve renal system, hepatic system, anywhere. It can go to any
exactly.
extent. So that is the thing, that whenever it's a good learning thing, that whenever a patient comes with fever, then IgM ELISA is one of the thing that has to be considered in most of the time.
Here I would like to add.
Yes.
Dr. Jayashree, ma'am, please go ahead.
Good
Please.
evening. Sorry for
Yeah.
joining
Welcome,
late.
Dr. Jayashree. Please go ahead now.
Thank you. See, we have had a few cases of. Hello.
Yeah, we can hear you.
Yes.
Yeah, we have had a few cases of leptospirosis. Start with when we were not aware of it, but when the physicians came in, they wanted to add it as another final test.
Jayashree madam, we are not able to hear you.
Make out whether. Hello, am I audible?
Yeah. Yes, now we can hear you. You were saying about physician asking for the final test.
Yeah. Then finally, we were able to get the diagnosis and we were able to save both the patients. And then so here comes the point that
Yeah.
you should have the suspicion to start with.
Yes.
So ask early wherever they are coming from. And if it is a case of fever, don't just say it is dengue or chikungunya or something like that. But think it could be a case of leptospirosis and do the necessary tests also and ask for the history, whether the rodents are there and whether she had any possibility of stepping on the thing or flood water, all those things. It's very early questioning is very important. Early diagnosis is very important and early treatment. And one thing I want to ask Jyotsna is, if she has had an earlier diagnosis, what was the prognosis? If the diagnosis had been delayed, what was the prognosis?
Ma'am, the data that we I mean, since we had collected the data retrospectively, what I could see was the patients who had presented, and the delayed diagnosis was there in one patient, which was where she was referred with a delayed diagnosis, and when she came here, she was diagnosed by the medicine people as leptospirosis. She ended up in a mortality, ma'am. She had this Weil's disease. She presented with IUFD with deranged LFT. Picture initially presented as if she was a case of AFLP with a fetal demise, and then things were being worked on. As per her papers, it was like the primary person who was treating her had always considered her as a AFLP patient and sent her to us. Okay, so the thing was, again, I would like to make a statement that this study did not have a exact reference to the point that, how long the patients were, since I have not direct contact with the patients. So I don't know when they came to the hospital, here the diagnosis was made, because at our institution, it is mandatory to send IgM ELISA for fever patient. So in general, when we send fever profile, it consists of RMAT, it consists of dengue NS1 antigen, and it consists of IgM ELISA. So how long the patient is being missed was not the data that I could get basically from.
Stemming from that, one thing you can also do retrospectively is look at the fever panels of non-pregnant and pregnant and see, since you're doing it routinely, whether it is more common in pregnancy than in non-pregnant age-matched controls, women.
I definitely.
Yes.
Thank you.
So those were really good insights, especially Dr. Mala, Dr. Kavita madam, who spoke about research methodology, and even Dr. Sanjeev sir told us about statistics part being not so advanced, where you had comparative groups. And then take home message, as Dr. Jayashree mentioned, that high index of suspicion is really very important in such cases. We cannot completely rely on physicians, and you have your say in this and to manage the case.
One
Apart from
question,
this,
how much does the PCR cost and how much does the serology cost, Dr. Archana? Do you have any idea?
Sorry, ma'am.
No.
It is being
And
done
Dr.
by
Jyotsna
the
is,
in-house. It is done in-house. So,
which is the gold standard actually laboratory diagnosis?
Matt,
Ma'am, they say that microscopic
MAT.
agglutination test,
Yeah.
yes,
Yeah.
MAT is the
Yes,
gold standard,
yes,
but WHO says that MAT is tedious, ma'am. It requires
it is.
expertise. So if in case we don't have that, the IgM ELISA test
Yeah.
can be done, and
Yes.
the
Yes.
diagnosis should be considered, even if they say that IgM ELISA is a spurious report, or it is like it is basically positive for a longer duration. Still, if IgM ELISA is present, please treat the patient. This is what WHO has mentioned in its guideline, that on the
Just
basis of
treatment
IgM
is
ELISA, we can treat the patient for leptospirosis. But
treatment is
definitely,
so
MAT is
simple.
the MAT
yeah,
is the
sometimes
required.
we treat the patient without knowing the thing with azithromycin or with amoxicillin, so that
Yes,
gets diluted and goes away.
that's right.
We
That is
have
so
vivid experience
rampant.
of, yes.
No, I
So,
think what I, sorry, there was a very strong thought coming to my mind that lessons we have learned from syphilis can be kind of propagated to leptospirosis because they're both spirochetes. And the same thing, the MAT test cannot be, it's very tedious. So also for syphilis, but the antibody testing is better. And I think if the PCR is readily available, that would be a great idea. That's why I asked the cost, because I don't know. Anybody knows, then please
So
let me
I
know.
think all these tests have been done in a public hospital, so I don't think so anybody would know the cost. And
Okay.
outside in private, we don't come around these cases. So like, I doubt whether anybody would be knowing the cost unless we have somebody from the path lab or something.
Right. I'll check on
You can
that.
always ask. Yeah.
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 So, Dr. Jyotsna, I wanted to say one line in defense for your presentation, that this is like a observational descriptive study, which is the first step when you're actually talking about an uncommon disease or health issue. Maybe later on you can do some case control study and other type of a study design. So I think this is a very nice initiative, and I would love to see that you take it across beyond Maharashtra also. And let us have
Sure.
some regional data also, other regions.
Yes.
For that,
This
I've
was
been
definitely,
asking
I'll tell you, this was
ICOG.
definitely an observational study, because after this article was published, I did get an inquiry. Not that this was accepted under my tenure, it was accepted under previous EIC, but it got printed under my tenure. So I did get an inquiry from somebody, a physician, wanting to know the details, how they'd gone about this and that. So I had to contact the Jyotsna and the other primary author and try and dig out into how they had come out with all these things. And then we realized it was just an observational thing, because they realized when they saw so many cases of leptospirosis, so many of them were pregnant. So that's the reason the gynec department became little curious about it, and they wanted to follow these patients with positive results during pregnancy. And that's how the whole idea of the paper came.
No, I wanted ICOG to take an initiative to make it 4 zonal, because
Yeah.
this has been on my mind that why not have a big hospital in each zone collecting the same data
Correct. So
and
this is
making it
mainly
a.
an initiative by preventive and social department, PSM department, because they have to figure out how many of these diseases are prevalent in which area and in which season. So that way they can take some preventive measures. So this is basically dug out from PSM department.
PSM. Right.
Okay.
So,
Thank you,
ma'am,
Dr.
the
Joseph.
ELISA test costs something between 1,300 to 2,500
Acha,
rupees.
Pradnya has come out with
Yeah.
Very
And
nice.
Metropolis is charging 2,500 for NAT,
Okay.
just around. But even we see
these
a lot
are
of
the
cases in Sion
4,000.
Hospital of leptospirosis, and they have a lot of adverse outcomes. We
Right.
have also noticed.
In Punjab also we are seeing, very rare, but we do get.
Okay. Thank you so
Yes.
much. Thank you, Pradnya.
Thank you
Yeah.
very much.
Sunil, we can
Dr.
go to the
Parag, sir,
next
you want to
one.
speak anything?
No, nothing. I'm just enjoying the
Yeah.
discussion.
Yes. Thank you, Dr. Jyotsna. It was indeed a very fruitful and nice presentation. This is a critical appraisal of the journal article. So the take-home message for the postgraduates especially is this is a stepping stone for any good case control and prospective studies, which should qualify later for good RCTs, systematic reviews. So never mind, especially such a large hospital should have so good data so that we can go ahead with the retrospective. Thank you very much.
Yeah. Thank
So
you, Dr.
hereby
Sunil.
now, thank you.
Yeah, yeah, thank you.
I request chairpersons to introduce our next speaker, Dr. Vishnu Priya.
Shall I introduce? Hello.
Yes, please.
Yes,
Yes,
ma'am. Yes,
please,
ma'am.
yes,
Go ahead.
please, please.
So the next speaker is Dr. Vishnu Priya, and currently she's a professor at St. John's Medical College Hospital. She's been awarded with the best outgoing student in her final first year MBBS, gold medalist in so many subjects, and she has won so many prizes. And she's also ex-executive member of BSCOG, UG and PG teacher with 20 years of experience. And I think she is going to present on obstetric and neonatal outcomes among patients with obstetric antiphospholipid antibody syndrome. And this is a prospective observational study comparing patients receiving conventional therapy and patients receiving additional hydroxychloroquine. So welcome, Dr. Vishnu Priya, and over to you.
Thank you, madam, for the nice introduction. I'll just share my PPT.
Ma'am, we can see your screen. You can start PPT presentation as a full screen presentation and you can go ahead.
Can you see my screen, Sunil?
Yes, madam. We can
Yeah.
see your screen. You can go ahead. Yeah.
Thank you, Foxy ICOG, and for giving me this opportunity to share on this platform. And my research article, my study is obstetric and neonatal outcomes among patients with obstetric apnea, a prospective observational study comparing patients receiving conventional therapy and patients receiving additional HCQ along with the conventional therapy. I bring greetings from St. John's Medical College, Bangalore. And the contents of this presentation would be introduction, materials, methods, results, discussion, and conclusion. As we all know, obstetric apnea syndrome is a condition that can result in a variety of manifestations like recurrent pregnancy loss, preeclampsia, abruption, intrauterine fetal demise, to name a few. Well, there are many other reasons for recurrent pregnancy loss that which is attributable to apnea. This is the condition that is increasingly recognized. One can consider that the successful management of apnea syndrome related RPL using the drugs like low molecular weight heparin and other immunomodulators like HCQs as a triumph of modern medical sciences. Recent years have clarified the diagnosis of apnea, and constant revisions have happened in the field of diagnostic criteria. Way back from 1999, the criteria have been started revising. Initially, it has started in 1999, then 2006. Latest 2024, you can see the American College of Rheumatologists and European, that is EULAR guidelines, have come up with appropriate usage of diagnostic criteria, which has been published in 2024. Once the patients have been diagnosed with apnea based on either clinical presentation or laboratory diagnosis, they are managed with heightened vigilance from the multidisciplinary team, including obstetrician and immunologist. And then the patient is taken care of from them. For the longest time, or from the time immemorial, the mainstay of apnea, we all know, has been aspirin and heparin. In recent years, there are some variations in the treatment in terms of addition of HCQs or substitution of conventional therapy with HCQs have been attempted. The decision regarding the choice between the anticoagulation or HCQ or additional therapy depends upon variety of factors. So those with APLA positive status without prior thrombotic episode or obstetric episode complications may be given or should be given. It's a recommendation from Royal College and the NICE guidelines, which says that any chronic immunological disorder with positive status, either SLE or APLA, those women should be started with low dose aspirin before conception, that is preconceptionally, which is associated with a better pregnancy outcome. So for those with APLA positive results with previous miscarriage, so this is obstetric APLA, we have two options. That is, one is low dose aspirin with low molecular weight heparin, that is anticoagulation, or second option being adding HCQs to the anticoagulation. However, the clarity regarding the choice of the two agents is lacking, and this forms the basis, and this is the need for the present study. The recent literature available regarding the usage of HCQs has been summarized below. So there is an article which says, which is published in 2017. It's a Chinese article. They have analyzed patients APLA with RPL. A 5-year analysis has been done, wherein group 1 received anticoagulation, group 2 received anticoagulation and anti-inflammatory agents like HCQ. Definitely, they saw group 2 has performed better than group 1 in terms of neonatal birth weight, proportion with low birth weight, and small for gestational age. And it is quite statistically significant with p-value less than 0.05. So, an addition of an anti-inflammatory agent to anticoagulation definitely improves the pregnancy outcome. There is another article which the European experience has been demonstrated. Of 35 pregnancies, again they have grouped the mothers or patients into two groups with conventional treatment managed APS and the APS managed with the conventional with HCQs together. The main outcomes seen are reduction in the stillbirth in terms of almost 4 times reduction from 80% to 20% with statistically significant p-value, and people who had prior IUDs also have appeared to benefit better with the addition of HCQ, and they have seen in the European experience higher dose of HCQ, that is 200 milligrams twice a day going up to 400 milligrams was associated with the better pregnancy outcomes. So they also emphasized that there is an entity called refractory obstetric APS with addition of HCQs and should be further studied. And there is one more article that has come up in 2024, which is latest, which says they have analyzed in this paper the RPL cases with low titer antibodies. That means these patients have not met the traditional criteria of APLA syndrome. They again grouped the patients into two with conventional treatment and with the HCQs. Definitely group 2 has done a better performance in terms of live birth proportion rate, but the difference is not significant. It didn't achieve the statistical significance. So need for the present study was, few studies showed benefit. There was one study which showed benefit, but it was not statistical significant. So we had come up with the study which with institutional ethical clearance taken in December 23, and it was a prospective observational study from then on. Patients were recruited at the first point of contact with the obstetric department and were followed up till delivery. They were excluded from the study if they didn't deliver in this institution or if any records were missing. The profile are the characteristics like demographic characteristics, obstetric history, immunological history, and any other autoimmune comorbidities like coexisting ITP, SLE, polyarthritis. All the details were noted along with the current pregnancy details and delivery details. According to PCOT, P is population wherein the standard diagnostic criteria were used to include the patients of APLA positive status. The exposure, we have seen that these treatments are started by the immunology department. So total there were 29 patients which were observed in the 1.5 years study period, in which 19 patients received low molecular weight heparin, aspirin, and HCQs. 12 received only anticoagulation, and the outcomes observed were obstetric, neonatal, and hematological outcomes. And the time period was throughout pregnancy, as I have described. The results are as follows. First table gives an idea about the baseline characteristics. If we take the baseline characteristics like age, BMI, these were comparable and not statistically significant. Past obstetric history like prior abortion less than 10 weeks, more than 10 weeks, IUD and FGR in prior pregnancy are also comparable but not statistically significant. Again, continuing with obstetric history, in groups which received anticoagulation and HCQ and versus a group which has only anticoagulation, that is HCQ and non-HCQ group. As I have described, it was 17 in HCQ group, non-HCQ was 12. Here, the obstetric history was in terms of PIH in prior pregnancy, prematurity, abruption, and thrombosis. These numbers were also comparable, but none of them were statistically significant. But when it comes to the autoimmune comorbidity, that we can say as a secondary APLA associated with either inflammatory polyarthritis, ITP, or SLE, in HCQ group, where there were 17 patients, 12 had associated conditions like Evans and polyarthritis. But in non-HCQ group, only one patient had this comorbidity. So, which was quite statistically significant. When it comes to the HCQ group, only out of 17, 7 had ITP. Out of 12, 1 in non-HCQ group had the ITP. When it comes to SLE with APLA, 4 out of 17 had SLE. None of them were, no SLE patients were seen in the out of 12 patients. So, to conclude, HCQ's usage is driven by the presence of chronic comorbid immunological conditions, and these were quite statistically significant with the p-values less than 0.005. The outcome parameters were, these were the medical outcome parameters in the sense, HB at the time of admission for delivery, presence of anemia and thrombocytopenia when we consider these three values were comparable and they were not statistically significant. But surprisingly, we saw in a patient who received HCQ, there was increased need for platelet transfusion. This was an observation which was made compared to non-HCQ group, and it was quite statistically significant. And another outcome was hypertensive disorders was almost, we can see the reduction, a significant reduction in HCQ group in the sense 17% out of 58%. So in HCQ group, it was 17%, but without HCQ, we can see almost up to 60%. Again, it is statistically significant. When it comes to the obstetric and neonatal outcomes, like gestational age at delivery, 36 weeks, and prematurity, cesarean section rates, birth weight at delivery, NICU admissions, and neonatal demises, all were comparable and none of them were statistically significant. So to summarize, HCQ's addition is driven by the presence of chronic comorbid immunological conditions. HCQ's addition appears to reduce the hypertensive disorders, which is one of the reasons for the maternal morbidity and mortality. HCQ addition appears to increase the need for platelet transfusion. So in discussion, I would like to say this was a study focused on comparing the outcomes between those receiving HCQ and who are not receiving HCQ with established obstetric APLA syndrome. Both groups showed a take-home baby rate of 100%. This reconfirms the effectiveness of treatment of APLA syndrome. This is a multicentric study where I have contributed from St. John's Medical College Hospital way back in 2020. This is a multicentric study conducted by, it's a collective effort by the Karnataka rheumatologists, but they have studied maternal and fetal outcomes of lupus pregnancies. Again, it emphasizes that HCQ use was associated with a reduced risk of flare. That is also statistically significant. So, and we have contributed from our institute almost most of the patients. So 80 SLE patients and 121 pregnancies were studied in this study. Then, what is this HCQ in pregnancy and how it is underutilized? In our study, there was only one case of dysmorphology and polydactyly, but whether this could be attributed to HCQ could not be clarified conclusively. So usage of HCQs appears safe throughout pregnancy. This is the latest journal Clinical Medicine. 2024 says it is quite safe, modern management of pregnancy in SLE patients from prenatal to postpartum says about the safety of hydrochloroquine in pregnancy. So again, in 2025, we have a latest recommendation from EULAR, and it is a 2024 update, which says DMARDs, that is disease modifying anti-rheumatic drugs that are safe with pregnancy are HCQ, cyclosporin, azathioprine, sulfasalazine, and tacrolimus. Following drugs should be discontinued before pregnancy. Like these are class D and class X drugs like methotrexate, cyclophosphamide, and mycophenolate. Preferably, once we stop, the window period is 3 months, so we need to tell the patient. So at least 3 months she has to avoid the pregnancy once she discontinues with these medications. So in a real world pharmacological treatment analysis, this is a study article from China. It was observed that the usage of HCQs has consistently remained one of the most popular drugs used for rheumatic conditions in pregnancy. Though there is a trend of usage of newer molecules, as I have described in previous slide, like sulfasalazine, tacrolimus, even steroids like prednisolone, azathioprine. Even though there is a trend of usage of newer molecules, the usage of HCQs still remained a favorite among the rheumatologists. Coming to the Finnish cohort, which had also lamented that only 30% of the patients were using HCQs, thereby this is an 18-year study, which says that it highlights a gap in the utilization. So it is underutilized for rheumatological problems in pregnancy. So what are the various determinants of HCQ usage? The presence of coexisting autoimmune disorders like SLE, the other conditions which we have discussed, increase the chance of patient receiving HCQ. The present study was an observational study where the patients continue to be monitored and followed up by a multidisciplinary team approach. While the obstetric parameters were being managed by an obstetrician, the decisions regarding the immunological drugs were taken by this department, which was not influenced by the conduct of the present study. HCQ usage and reduction of the hypertensive disorders, which we have discussed in detail in results. The occurrence of hypertensive disorders was much less, 58% over 17% in HCQ group compared to the non-HCQ group. This is one of the most important findings of this present study. This finding is also mirrored in the small study by Stavros et al., but not in the study by A et al. Because hypertensive disorders, as we all know, directly or indirectly contribute significantly to the maternal morbidity or mortality. This significant reduction with addition of HCQ must prompt a higher utilization of HCQs. The pathophysiological mechanisms which get altered after HCQs need much more exploration using molecular studies. So I have got one study which was conducted in India itself, which says that they have evaluated or they have demonstrated it is done in small group of 7 blood donors, volunteers, and they were non-pregnant patients. When they have given HCQ, that group needed a much higher platelet transfusion. We can explain this through antithrombotic effect or mechanism of action because HCQ has antithrombotic effect also in the sense it inhibits the platelet aggregation compared to the non-HCQ group. So it has antiplatelet aggregation properties and HCQ platelets need further exploration. So to conclude, when antiphospholipid syndrome has coexisting immunological problems, adding HCQs may be considered. Addition of HCQs may result in reduction of hypertensive disorders. Higher rate of platelet transfusion may be needed in patients receiving HCQs, so we need to be alert. Addition of HCQs gives equivalent delivery and neonatal outcomes with significant improvement noted in the present study. Further studies regarding HCQs in APS are needed. And I thank team JOGI and ICOG. And my special thanks to Dr. Sujata Dalvi and Secretary Dr. Sunil. And I would like to acknowledge my team, Dr. Shobha, and my postgraduate Lisa Svita and Madhva Prasad, without whose support this would have not been possible. Thank you. Thank you so much.
Thank you very much, madam. You can stop sharing the screen and then we can have discussions. Dr. Jayashree, you are mute actually.
Jayashree ma'am, please unmute yourself. You are muted.
Okay, can I make a comment in the meantime?
Yes, yes, Dr. Mala, go ahead.
Yeah, so I enjoyed your presentation, Dr. Vishnupriya, but of course the numbers are very, very small. And I think you need to carry it forward with larger numbers. I'm sure you know that.
Yes,
But
madam.
one thing that this HCQ was, which stage of pregnancy did you start the HCQ? Was it pre-pregnancy with aspirin or early first trimester or second and third trimester?
It is started in both ways, madam. It was started in few patients who had the chronic comorbid condition, even pre-pregnant also.
Yes, because
Yes.
that's what's happening now. Most
Yes.
people, because of its safety, but FDA category for HCQ is still not classified.
Not classified.
And otherwise, it's a category D where it says only use when benefits outweigh the
Outweigh
risks.
risks. Yes.
And I think we still need more data on HCQ in pregnancy, which is something I don't know if you have studied if you came across studies that looked at it, large studies.
Yes, see, there is a study in American Journal, but that has been done for COVID pregnancy
Yes,
and
yes, yes, yes.
anyway, the same thing. It's going to have the same effect on the pregnant lady and on the pregnancy and on the fetus. So
Right.
that is first trimester usage is to be, you have to be very cautious because still it is not confirmed that there will not be any congenital anomaly. Later on stages, probably later on trimesters, it can be freely used. That's what is the statement.
Okay, thanks. Yes, thank you.
What I would
Dr.
say is
Jash.
if patient has a comorbid condition and she has already started with HCQ in pre-pregnancy, and if she becomes pregnant, it's always better for her to continue with the
Continue.
HCQ.
Yes,
Yes, because if she does not continue, then she could have some pregnancy mishaps. So it's always better for her to continue
To continue.
because she's
But
already having something of that sort, yeah, right in the
can I
beginning.
bring to your notice, Sujata, that
Yeah,
a
tell me.
lot of us see APS syndrome with
Correct.
one positive result, which now the latest EULAR guidelines are saying should be treated, but the earlier guidelines said unless the second test 12 weeks apart is positive, you cannot treat it. But this low titer, one positive result, most of us clinically feel safer giving her just HCQ than to give her low molecular weight heparin, which is expensive. And
And
that
it's a
is where
daily injection they have to take. So, yeah,
exactly.
that also
So
takes a little bit load on them.
she has one miscarriage, she has one positive test, and now she's with you in the second pregnancy, and you don't know whether it was APLA or what. And what you feel safe doing is, okay, let's give her HCQ.
Correct. And what patient wants is a result, in the end. Whatever you give it to her, what she wants is a positive result in the
But
end.
we don't have data of its use
Correct.
in the
I
first
understand that. Yes,
trimester.
I
Yeah, so
understand that.
that is.
But whatever it is, we always try to give for the benefit of the patient. So I think we can still continue with
Yes.
this.
That's right. But giving it in the first trimester, I'm still having my own doubts.
But we
I
may not start in the first trimester, but what I
Yes.
said was if she is taking it in pre-pregnancy and if she becomes pregnant, then it's always advisable for her to continue and not to discontinue that HCQ. That's all
Okay.
what I meant was
Yes.
that.
Yeah, just like metformin and GDM, I mean PCOD.
In PCOD, yes, you would want to stop it. So same thing with this also, you would want to stop it. And it gives a good
Okay.
results because I had my patients who've got good results. Not that I have so much of
absolutely.
data, but I
Okay.
did have a good result. So that's the reason I'm just
That's
thirsting upon this idea, nothing else.
right. No,
And
I
Dr. Vishnu Priya, I think it was a very nice presentation, and I really liked how you did a literature search and presented some of the previous studies related to this.
Thank you.
I have few questions for you. First is like in the first group where you gave SCQ, it was more like a secondary APS where they were having some underlying autoimmune disease.
Yes.
While in the second group, I think one patient had that was more having primary APS patients, I think. So how can
Yeah,
you
the
extrapolate your findings in group 1 to 2? Because one is a secondary APS and the second group is only primary APS.
Yes.
So we cannot say that HCQ is actually beneficial in those with primary APS where there is no underlying autoimmune disease. Can you
Even though,
justify?
yes, madam. even though it's a primary APS without comorbid, associate comorbid autoimmune conditions, it could be like uh, it could be an obstetric APS, madam. Like with the previous miscarriages or preterm delivery, we have an obstetric APS and the thrombotic APS. We are justified in giving HCQ because there are studies which say that HCQ addition along with it, which has the anti-inflammation, gives the better obstetric outcome than without HCQ.
Yeah,
So
I
this could
accept that.
be obstetric
There's
APS.
underlying autoimmune diseases like SLE, ITP, and all. But for primary APS,
No,
because I'm
primary
sticking to your
obstetric
study.
APS
What
is
she's saying is
Sticking to your
obstetrics.
study.
In primary
Because-
obstetric APS, there is once again we have an obstetric APS and thrombotic APS, madam. In a situation where there is an obstetric APS, we are justified in adding HCQ because it is associated with better obstetric outcome.
But the comparison in your study is a little unacceptable because the majority of the patients of secondary APS was in group 1 who received HCQ. And I think only one patient of autoimmune disease in the primary APS where
Yes.
you're not giving HCQ.
Not giving HCQ.
So how can you compare?
No, I get your point, but I think
Mhm.
there are already studies to say that obstetric APS is benefited by HCQ, and that is why
Ma'am,
this
I
is
fully agree with you.
catching
but
on like
I'm talking
wildfire.
about
I
your
mean,
study.
before we have safety data, it's just caught on like wildfire. It's used in pregnancy.
Yes,
And we
madam.
have had
For-
rheumatologists, and when we refer patients to them, they also advise HCQ. It's not that they are also reluctant. You
Yes,
send
madam.
them to them, and they will advise HCQ, and they have to continue. So they
Ma'am,
are also
about the-
propagating the
I'm
same.
not
I think
doubting
Alpha
the
also wants to
treatment,
say something.
but I
So may I-
have concerns regarding the research methodology. So
Yeah.
that is why I
Yeah.
put this
Yeah,
No, your
but
question.
point is
everything every time doesn't go in the same fashion. Sometimes you have to see plus and minus point and what results you get it, and that way maybe you can go ahead with that. Yeah, but Dr.
No,
Madhav
madam.
wanted to say something.
Madam, one question is, one thing is, thank you, Dr. Vishnupriya ma'am, for your nice presentation. No doubt
Thank
about
you.
it.
Thank
But
you.
again, the same question here that it's one kind of non-inferiority trial because I think whenever we are choosing groups where ECQs has to be given, that has been done in these cases in this study that you have chosen inflammatory groups, ITP groups, and SLE groups for choosing these patients for giving HCQs.
Yes.
So hydroxychloroquine. So
Yes.
then, we definitely, all of us know that hydroxychloroquine is very safe in pregnancy, and the rheumatologists, they very often used to give it for any rheumatological conditions in pregnancy, and they also started from the very beginning of pregnancy, even from the first trimester, without any hazards so far now. So here in this case, ma'am, something, I mean, the data has been little bit skewed. SQs were used in a group. I mean, rather than doing that, if we can give in a two groups where only there is APLA, obstetric APLA, primary APLA, and there is no other thing like SLE or ITP or inflammatory polyarthritis or like that conditions. So in these two groups, we can give one group low molecular weight heparin aspirin and another group low molecular weight heparin aspirin and hydroxychloroquine.
I
Then we
agree
can
with
go
you.
ahead
Yeah.
and to see whether that is actually decreasing the incidence of hypertensive disorder or
Yes.
that is causing how much problem in the platelets. So
Very
that
true.
is the thing we can go about it.
Very true. I agree with you, sir. But
Mm.
this is the management started from the immunologist side. We have not, like, say, already we have taken the APLA positive patients who are on treatment. Then we have
Ma'am,
That is the immune
hydroxy,
department,
yeah,
immunology
yeah,
department.
but
HCQ group, non-HCQ group. There we
our
have seen
main
the outcomes and the results.
our main idea and motto is to understand whether we can give hydroxychloroquine to those group who are not suffering from any kind of polyarthritis or SLE or any kind of
Yeah.
multiple connective tissue disorder. That is our
Agree, sir.
main motto, isn't it?
Yes. Yes.
So if we
But
want to know
one more
that
thing
part,
is, yes.
yeah, if we want to know that part, then it has to be distributed like that only.
Agree, sir.
Yeah.
Yeah, but for that you need to have many cases, and it's difficult to get that many cases. So it might take little more time to figure
Yes.
out that
Yes.
part of it. Till then,
Multi-center
whatever the
study.
immunology
Yeah.
department or your rheumatologist tell you, I think they should go ahead with that.
Our rheumatologist, when we refer them when we refer the APLA cases to them in early pregnancy, they start them on hydroxyquinoline. But what happened? Two of them had intractable vomiting and they had to stop in the middle.
Yeah,
So that
gastritis
was the
is
problem.
early pregnancy gastritis is a known complication, especially if they have H. pylori prior to
Correct. Yes,
pregnancy.
that is true.
Yeah.
Yeah.
So
But
what was
one
the
more
dose
thing,
of aspirin that you gave, Dr. Vishnupriya? Dose of aspirin.
150 milligrams.
even pre-pregnancy,
Yes, madam.
because normally the guideline is 75 pre-pregnancy, step up to 150 later. And also, I was thinking, the need for platelet transfusion more with the HCQ group, because both aspirin and HCQ are antiplatelet.
Antiplatelet. That is
And I think at some point we will have to look at whether HCQ can replace aspirin and we give just HCQ and LMWH, because they both
Continuum.
are anti-inflammatory, whereas aspirin is not anti-inflammatory. Aspirin is only antiplatelet. If HCQ is both antiplatelet and anti-inflammatory, I think at some point a study is needed where you give one group just LMWH and HCQ and eliminate the aspirin. And I mean,
Because of articular
it'll
prevent.
need a little hard to do it,
Yes.
but I think that will reduce your complication rate.
Yeah, that is true. That's a good idea. New
The
idea.
problem is whether HCQ will replace heparin or HCQ will replace ecosprin. I mean aspirin. So that's a big question. I
No,
mean,
because it's low molecular weight heparin is totally anti-complement. Its mode of action is very specific for APLA. Whereas aspirin, we just used it as an antithrombotic
Antiplatelets.
and
Yes.
antiplatelet. So I don't think it'll, oh,
But it
maybe
has minimal anti-inflammatory effect also. Aspirin is again an inflammatory.
much less than
Very
HCQ.
Less than HCQ. Yeah.
I think it's a very fruitful discussion we had. And
We go to the
that the
next
very
one.
fact
Yeah,
that
yeah, Sunil.
the very fact it elicited such responses certainly means it's of great importance. So many congratulations to you, Dr. Vishnupriya. It was a wonderful presentation, and
Thank you.
I think we'll really think
Yeah,
of
so
taking
we
this forward.
can.
Should we go to the
Thank
next
you.
one,
Thank
please?
you all the
Thank you so
faculty and
much.
thank you all
Thank
the
you.
chairpersons. Thank
Thank
you,
you,
Radhika madam, for the inputs, and Sujata madam. Now we'll move ahead with the next topic, which is a software presentation introduction. I request chairpersons, they can be there for the program.
Sure.
I'm Dr. Sunil Tamvekar. Currently, I'm working as assistant professor at Vadi Hospital, and I'm assistant secretary, JOGI. Today, we have task of describing. I would like to share my PPT presentation. One second.
Yeah, so as a brief, I think it would be in place for us to also inform that Sunil would be actually telling us sensitizing in terms of Grade Pro and Agree to softwares. So in the next meeting that would be in September, we would be also undertaking the software live demonstration, because both of these are very important, and it's very important to also understand the basic fundamentals. So over to
I'm
you,
very
Sunil.
impressed. I'm very impressed with the journal committee for going for the agree to and the software, right?
Yeah, so it is high time now, Dr. Mala, as you would agree.
Mhm.
So, because these have barely been touched in most of the obs and gynae fora. So
Yes,
we thought it
yes.
was extremely important to sensitize people about these at least before we start using them also.
Thank you very much. So we are going to have introduction to these two software tools, which is Grade Pro as well as Agree to. So we all of us are aware that the highest level of research is meta-analysis, where researchers will compile all the studies together and develop the meta-analysis, giving rise to evidence for your clinical questions, or if at all there have been repeated hypotheses being generated. which will be used by the organization clinical bodies to develop the guidelines. So we always hear ACOG recommends, WHO recommends these green top guidelines by RCOG is giving these. Where do these guidelines come from? What does the researcher or the committee person does exactly? How do we know that these are trustworthy? And what if there are guidelines? Why do different organizations they disagree? So here comes the necessity of the research uh, tools or tools developed from the guidelines, which are going to make guidelines transparent. You can see how decisions were made. The guidelines, the results would be evidence-based, not just an expert opinion. And the results are consistent, where same standards are applied everywhere, and you yourself can use those softwares to see how those results were generated. As far as Agree to and Grade Pro is concerned, you consider it as a quality filters for these guidelines. What is Grade and Grade Pro? So this particular software or body, which is helping researchers worldwide through their website and then software, it is an acronym for grading of recommendations, assessment, development, and evaluation. The evidence which is generated, it is going to tell us the how good is the evidence. It is a high, low. So they have system for that. How strong should the recommendation be? So what does it exactly does? It organizes all the studies in a simple table, creates an easy to read SOF, what we call summary of findings, and generate the evidence. High, moderate, low, very low. I'm sure you have come across through such kind of research terminologies when you read the guidelines and decide whether it is strong or not. So this is a screenshot through the website where there are few free software work is available and then they're quoting prices here. Once you log in, you will so this is some projects we were working on. So
Yeah,
I
I
am
just
going
wanted to add
to
to whatever you have said, Sunil.
yes, madam. Yes, madam.
This website we are also going to be demonstrating since we are going to do that in the next class, in the next meeting. So it would also be a good idea to say, basically, to summarize that Grade Pro helps us to identify the strength of evidence and the quality of evidence and the strength of recommendation. So it helps us to understand the quality of guideline that we have finally been able to arrive at. So with that background, that is why, today we are all talking about recommendations. It is high time we talk about guidelines. And that was the reason why Sunil and myself, we both thought it would be a good idea to have a brief introduction to Grade Pro. So over to you, Sunil, back again.
Yes, madam. So just brief overview of this screenshot and the software itself. It takes you to the dashboard where you are working. Then once, see, these are the projects for a demo purpose we have got. Okay, fine. So directly right now I'm entering into this project where we are comparing progesterone to prevent preterm birth, vaginal progesterone versus placebo, that is no treatment, and so forth and so on. You can develop your questions, research questions or PICO question, which you will have to add here. Project setup.
So you
Yeah.
basically
So
need to get all those studies together, identify the biases. There are 8 biases that are there. So a graphical representation of those biases is done, because what Dr. Sunil is showing here, like he said, 5 studies. So study designs, could all those studies be different? So that is why the live demo would be in the next class, probably
yes,
clarify so many doubts that we will be having. And then
yes,
because the weightage of a randomized trial is very different from that which is given to an observational design. So this entire Grade Pro software makes it extremely transparent as to how this guideline was formulated, and thereby also giving us the robustness of the outcomes and the recommendations that one is giving for each outcome in these guidelines. So that is the beauty of the entire thing. Other than this, it also takes into account the stakeholders' point of view, what the patient thinks with respect to the treatment. What I would think as surgery be the very best one for a condition may not be what is acceptable to the lady. And that is why, Sunil, can we see that again? The important critical outcomes. You just showed
Yes,
those outcomes there. So you
yes.
can categorize each of these outcomes into critical, important, not important, and then based on all these parameters that you select, finally the outcome, the strength of recommendation comes for the outcomes based on the quality of evidence. So that is basically the very brief summary of Grade Pro.
Yes. So quickly, if you can see this presentation, where Cochrane review, they have compared prenatal administration of progesterone to prevent preterm birth in multiple pregnancies. So this is a summary document, which is only like 4 page, and you can go through this detailed document where they are comparing the various outcomes. For example, okay, fine. The
Yeah, so
computer.
yeah, so
So
it is just
in
a
this
visual
particular
impression.
column,
Yeah.
which is quality of evidence, which is generated by grade. Okay. So as you can see, prenatal death outcome. Okay. So there is a, okay. So right now there is a problem with the computer. Doesn't matter. So prenatal death, they have compared in two arms, whether there was like no treatment and there was intramuscular progesterone. As you can see, there is no difference. In fact, in intramuscular progesterone group, prenatal death component was higher. So relative risk goes more than 1, that is 1.4. So, but what is the evidence? What is the quality of evidence? So it is low level evidence. So this is the importance of Gray and its contribution, that whatever these uh, 6 RCTs, whatever these 6 RTs is out of so many participants, 3089, the research, the evidence is generated, but that is of low quality. Uh,
So the quality is low because of those domains that you showed: inconsistency, indirectness, heterogeneity, different types of trials. So,
yeah,
so that is why this software helps us to determine that.
yeah. So this, I think internet is interfering like this. So it doesn't matter. So I gave one example of how grade contributes to Cochrane review.
And now even WHO has started using Grade Pro, and most of these WHO recommendations in the past 2-3 years are based on Grade Pro recommendations.
So ma'am, Cochrane, NICE guidelines and WHO, they are now predominantly using grade. Okay, so going ahead now, the next tool, what we are going to discuss is Agree. This is the way this grade gives you. What is Agree and what is Agree 2? It is also an online tool which is used to appraise any particular guidelines. Uh, the work which I may like, you may not like. The group of researchers, group of active clinicians can have their appraisal of the for the guideline under these 6 domains. So agree to is appraisal of guidelines for research and education evaluation. It checks guideline quality like a report card. So these are the 6 domains under which you're going to judge the guideline. So we can go ahead and see their few screenshots. So this is a big kind of organization. They are doing it for like charity basis, as well as they are asking for donations. And then, so this is a detailed website of them. You have to log in, you have to create an account, and this is agree to instrument. If you can see my pointer, I am not sure. One second.
Yeah,
This
we
is
can see. We can see.
agree to instrument, which is a large PDF document in which there is a checklist. But now they have made it simple with this particular area, My Agree Plus. So if you go to My Agree Plus, then it gives us a. So, for example, I chose to. I was going through guidelines or ACOG recommendations for hyperemesis gravidarum. So ACOG practice bulletin for nausea, vomiting. Manually, you have to insert all these things. Then
Actually, more importantly, one must be clear regarding the definition of those 6 or 7 domains. What is
yeah,
transparency? What is
yeah.
conflict of interest? What are those clarity with respect to? So each is defined. When you so this My Agree Plus is available. It's an online tool, and when you
Yeah.
click on each of these, the scope and purpose, stakeholder involvement, So they also give you a definition as to what it is, and it helps you to collaborate online. So when there are many people working together, it is always a good idea to have odd number of people, either 3 or 5 or 7 or 9, so that if there are any discrepancies, they can be resolved between two people. And the definitions of these domains are there, and one is expected to score them. So please wait for our next meeting in the month of September, where we will also demonstrate live, because due to shortage of time, we are just able to show you the
So we
screenshots.
had to describe this introduction in like 15 minutes today. As Madam had told, we are going to see everything in depth, which will be presented by Madam, which requires in-depth like knowledge as well as work under these various headings and research implications. Okay, so I wanted to show these 6 domains in detail, but with this,
So I think we can show it in the next class,
we can
because
show
I
it
think
next,
your
next presentation,
because
madam.
your
Yeah.
computer.
So as you can see, so under 6 domains, there will be 23 questionnaires, as you can see in the screen. So if any particular guideline you are opening, first you will go ahead with scope and purpose, under which there are 4 questions. And then it is going to guide you here, what to look and where to look and go ahead. So, okay. So I conclude my presentation today, which has got a take-home messages for all of us to understand how these guidelines are developed and how it is going to help us. So as a simple analogy, try to understand that these guidelines are like recipes. So Grade Pro helps us to write the recipe correctly, like ingredients, methods, etc. And Agree To is appraisal, which is going to check whether recipe is clear, whether it is complete, whether it is safe to cook. It matters for us because it is going to help us to pick up the best guideline for clinical management, make sense for conflicting guidelines. It's going to give us building trust in recommendations, what we are recommending for the patients, and prepare us to contribute to create our own guidelines, national guidelines like ICOG, FOXY. We can create our own guidelines and practice opinions. So Grade 4 builds guidelines for transparent evidence grading. Agree To evaluates. Together, it is going to ensure trustworthy recommendations, and OBGY can confidently choose and even develop better guidelines. Thank you very much. And so this is a take-home message for postgraduate, where your own studies and thesis should be of such a quality that your topic should be chosen for a systematic review by some researcher sitting in any country of the world, and then only it is going to become part of meta-analysis, and then it is going to become part of guideline, so that it is going to help the patients and disseminate the evidence through the guidelines. Thank you very much.
So thank you so much, Sunil. That was a very brief teaser for the two softwares. I think it would be just right for us to be giving a live demonstration next time. So thank you so very much.
Any comments from the chairpersons?
No, I'm looking forward to this. Please send me the information. I would love to, because if we want to make guidelines, they have to be robust. No point in putting in not robust guidelines.
Yeah, and I think we'll be able to implement it much better when they show us a practical demo next time.
Absolutely,
So this was
absolutely. I
just an
think
introduction, so it has gone in our mind that okay, there is something
most
like this.
international guidelines follow
Yes.
it, and we don't.
Correct.
So
And I think we should also follow it, because there are so many guidelines coming in India, but then we need to follow this. So I
It's
happy,
absolutely
so happy,
encouraging to hear
Sujata.
this, Dr. Mala. I think it is since the past 2-3 years, I've been extremely troubled that we are only talking about recommendations, GCPR. So I think it is extremely important today that Foxy and all of us get together and start talking about guidelines.
I'm so proud of Team JOGI.
So thank you for
Thank
giving
you.
it a backup support. Thank you so very much.
Thank you. You can give vote of thanks.
Yes, ma'am.
Or maybe Sunil wants to give. I leave it to either of you.
We are on time. No, I would like to request Dr. Pradna Madam to go ahead with vote of
Okay,
thanks.
I leave it to either of you.
So with this, we conclude this excellent discussion. It was a very fruitful discussion. Excellent presentation by Dr. Sunil. I would like to thank both the conveners, Dr. Sujata Darvi ma'am, Dr. A.G. Radhika ma'am, who have planned every program in a very, a lot of thought-provoking has gone in, organizing and planning the topics, and we are really thankful to you. We would like to thank the Foxy President, Dr. Sunita ma'am, ICOG Chair, Dr. Parag Binewale sir, Dr. Sheila Mane, Chairperson-elect ICOG, Dr. Ashok Kumar, Vice Chairperson ICOG, Dr. Suvarna Khadilkar, Ma'am, Secretary General, Foxy, Dr. Sarita Bhalerao, Ma'am, Secretary ICOG, and of course the Master of Ceremony for today, Dr. Sunil Tamvekar, and Nilima from ICOG, who has been the backbone in organizing this program. And we are looking forward to the next live demo, and the excellent discussion was conducted by our chairpersons, Dr. Mala ma'am, Dr. Jayashree ma'am, Dr. Kavita, and Dr. Sanjeev. I think you added a lot of fruitful discussion to these case presentations, and thank you so much for sparing your valuable time and attending this program.
Thank you, Pradhan. And I would like to say this time the chairperson took so much of interest in both the case presentation that there was lots of fruitful discussion with regards both the case presentations. So I would want chairperson next time also to come prepared like this so that we have a fruitful discussion, apart from the regular one. But today's was something special, I must tell you that. Okay.
Yes, yes. Dr. Kavita was excellent. So was Dr. Jayashree and
And
Dr.
so were you,
Sanjay.
Dr. Mala.
Ma'am,
It was,
all
Yeah,
because
but we want
good
some
to have all of you.
chairperson who will give us thought-provoking things.
Truly enjoyed
I
the entire
wanted
session
to be
today.
connected with all of you. So I was just writing in the chat box, can we have exchange phone numbers? But please, yeah, we would love to be connected.
Yes.
We will
Okay.
certainly
Sure.
Just-
invite you for the next one too, Dr.
Yes,
Mala
definitely.
and Dr.
Yes.
Kavita. I think it's all the chairpersons, and we can add a few more.
Yeah.
Correct.
Yes.
we
Yes,
can
sure,
add a
ma'am.
few more.
Yeah.
So I just
Definitely,
wanted to
Radhika, we will
comment
do
on
that.
Dr.
Yeah.
Sunil's presentation. It was very
Sunil's was
inspiring.
also
Dr.
good, yes.
Sunil, I'm already inspired to write and contribute to certain national guidelines. Very nice.
Yeah.
I
Thank
think
you.
that was
Sunil
a
has
nice
been working on it last 1.5 months. Every
Yeah.
now and then he's telling me, Madam, this, that, everything, Every now and then he's doing so much of research and getting it sanctioned from me.
Yeah, I think Sunil has chosen the topics also very nice, interesting topics, and I think that is the base of the entire program, that you
Yeah,
choose
but
good.
Pradhan, you are also no less, yeah.
Yeah, we are supported by a
understand
very
that,
dedicated and active team. So
Yeah.
thank you so very much. Thanks
The
everybody for being here.
presenters were very
Thank you.
good. I think they were the backbone. The presenters too. I think we should thank
Yes.
them.
Yeah,
Yes,
they
yes,
did a
the
great job.
presenters did an excellent job, and their
They've
articles
done
have been
work on that.
published.
See, they've done work on that, so they know what they're reading it out.
Yes, yes.
Anyway, chalo,
Great.
bye.
So thank you so much.
So
Good evening
next
all.
program
Thank you,
on the
everyone.
second
Thank you.
Tuesday of next month.
Yeah, okay,
So we will
bye,
be
bye.
looking
Most
forward. Bye.
important
Bye
part
bye.
of
Bye.
the
Thanks,
Bye.
everyone.
program
Yes.
is
Thanks.
Journal Club. So
Thank you.
congratulations for conducting it so nicely.
Thank you,
Thank
ma'am.
you. Thank you so much.
Thank you.
Bye
Thank you.
bye.
Okay,
Bye
chalo.
everybody. Bye.
Thank you.
Bye.
Thank you.